I think it's really important, especially in this day and age that we talk about precision medicine, that patients should be worked up. And I think getting the MYD88 mutation is very, very important, understanding its status in patients with Waldenstrom's. It will help in the diagnosis. It may have also a role in the prognosis, since we know that the patients that don't have the MYD88 mutation tend to have, decreased survival, but they also are at risk for increased transformation to aggressive lymphoma. So I think from the get-go, it really helps us make the diagnosis and also have a sense of the prognosis and also treatment. We know that with ibrutinib monotherapy, that patients that don't carry the MYD88 mutation, don't show those deep responses. But the 95% of patients that do, on the other hand, benefit with BTK inhibitors. So it's important to know that. Now, the L265P mutation is the most common MYD88 mutation. You see it in almost all the patients, except there's a small handful of patients that can carry non-L265P mutations. So if somebody is getting a PCR, workup for the MYD88 mutation and they come back as wild type, that might be because either that patient has a low disease burden or they may have one of these non-L265P mutations. In that case, you want to use Sanger sequencing or next generation sequencing to be able to determine that. CXCR4 is really important because it gives us a sense of disease presentation. Patients that have the nonsense mutations tend to be the ones that present with very high IgM loads, symptomatic hyperviscosity, and need to be treated sooner than later. So I think it's really important. And also, it impacts a lot of drugs. We're seeing now data, on ibrutinib, impacting deep response attainment and time to response. It's important to know this because then it sets expectation for the patient. And if you have somebody who needs an acute, response to therapy, you would take that into account. Also, from a development point of view, this is also a targetable mutation. So there's a lot of research now going on using CXCR4 antagonists, and I do think that if we were to have this interview maybe 5 years from now, there would be an action plan that would go with having a CXCR4 mutation. You'd specifically would treat that person with a CXCR4 antagonist. I think that's what's really exciting in that regard. So being able to get both mutations from the get-go, I think, helps you understand the patient and also help develop a comprehensive treatment strategy.